Hi and welcome. This is Dr. Aziz. I have BDS from Mosul University in 2007. I have a MSc in prosthodontics to 2015. And also I have a degree in digital dentistry. I'm a certified instructor for Blender in 2022. Today's topic is the vertical dimension and how to record it using digital scanner, oral scanner. So starting, we will discuss a little bit about full mouth rehabilitation. What is it? Defined as the restoration of the form and function of the masticatory apparatus to as nearly as normal condition as possible. The object of this work is aesthetic function, phonetics, preserve longevity of remaining teeth. Okay, we will take another definition, which is vertical dimension, which is the distance between two selected anatomical landmarks, tip of the nose and tip of the chin, most prominent area, one on a fixed and the other on a movable part. Here's vertical dimension, and we look here how it got reduced. Distance between two selected anatomic or marked points when in maximal intercuspal position, static and dynamic. Another definition called freeway space. What's a freeway space? When not in contact, the teeth are held apart in the rest position by the muscles of mastication acting on the mandible, creating a freeway space or inner occlusal distance of up to 4 to 2 mm. This is in normal dentition, but in other cases it increases. So the theme or the object of this lecture, we want to restore our vertical dimension to 2 to 4. A lot of our patients has like 6 to 7 millimeter of freeway space, so we reduce it to 2 to 4 millimeters. Okay, we'll take this video. See the translocation of the mandible from centric relation to centric occlusion. This is the point. We see this is the freeway space. He's in rest position. We'll ask him to close. Okay, we see how translocated from centric relation to centric occlusion. Go to the next slide. So we explained briefly about centric occlusion, centric relation, freeway space, vertical dimension, etc. We'll take our first case, which is this patient who came to our clinic looking for restoring his vertical dimension, restoring his aesthetic function, etc. We take as primary diagnostics, we take photos and scans for the patient pre-work. And I do something else. I determine the vertical dimension in his freeway space and how much he have lost vertical dimension and how much I will restore. This is in the diagnostic first visit of the patient. Tooth wear diagnosis. So you have here some points to diagnose tooth wear. Let's have more points. Okay, so this case we will discuss it. It's about rehabilitation of the full mouth without altering vertical dimension. So this patient came to the clinic. She has a reverse smile. If you look here to the right side of the patient, the 4 and the 5 are lower than the canine. So it's like the curve of a spee is much convex here. And also here. This is due to she has lost this teeth and didn't restore them for a long time, which led to migration of this teeth occlusally. That's another anterior photo. We see here the reverse smile is prominent from the 4 and the 5, also here. This is the... after I finished this case, I know there was something wrong. We didn't completely fix the problem of the vertical dimension of the I'm sorry, with a reverse smile. We didn't increase the vertical dimension. We just like cut her teeth down and restored her teeth, and we see here the canine. Still there is reverse smile. We didn't fix it as well. After I fixed it, after I finished the case, I noticed that, which make me wonder for the first case how I will. It's like a challenging case how I will fix it without going through this dilemma of reverse smile. So as we see here, the result was kind of beautiful. The patient was happy with her teeth, but I was not comfortable with this reverse smile, to be honest. So I told the patient we should change if you want. She said, no, I'm okay with it. I don't have any problems. So for the next patient, we came up with a new protocol of increasing vertical dimension at once. So if we take a look at her scan, this is Shining 2 scanner. Okay, if you look here, the curve of SP and the other curve of SP. So we see the concavity of the curve affecting the lower teeth because of the migration of the upper teeth. So this is her, that was the pre-op scan. This is the, after we started working. If you stop the video here, see we made the preparation. I can like make the curve of speed normal by reducing more, but this will affect the retention, resistance form, retention form of the fixed prosthesis. So, and we need some space for the zirconia. So as we know, when we prepare the teeth, it's proportional. Your preparation depends on the the space of your bridge. How long is it? There's a lot of things interfering with your preparation and the way you prepare your teeth. So in this case, I couldn't prepare more because I want to conserve the teeth. I don't want to like reduce the preparation more in sake of modifying my curve of speed. Okay, so I think we'll go to the next slide. Okay, so this is our main case, that severe attrition case. You see how much he tried to show his teeth when he was smiling. We were unlucky to capture anything of his teeth. So first of all, as we said, photos, scan, evaluation of the teeth, vertical dimension, how much we have lost vertical dimension. And started our work. This is another photo. If you look closely how his opening is increased, his vertical dimension is higher. I think the color is A1, patient chose the A1. So we make the preparation all at once. I'm a left-handed dentist. I started with left side and to the right side, upper and lower together. This is his scan. If we take a look at his scan, we see here the severe attrition apparent on his teeth. We see the facets of wearing all over his occlusal surface. So it's like his teeth are grinding on each other. So what we did here, we elevated his vertical dimension by like 3 millimeters. I made some temporary teeth and put it inside the patient mouth. We look here, we see the attrition apparent. If you go slightly more with the video. Okay, so this is his scan. If you look at his scan is like we take the scan on this vertical dimension. This is the core of this lecture, how to take a scan with this vertical dimension, the new vertical dimension. You know, the patient is anesthetized from here to all his sides. So how you can take a new scan with a new vertical dimension. You have predetermined you need this vertical dimension. This will serve you. So there is a lot of benefits from this vertical dimension. If you look closely, the teeth are long. We didn't reduce a lot from the teeth to have interocclusal distance. We used something like that did space, the freeway space, which we don't use it actually. We used it, and we elevated the vertical dimension. If you look here, maybe the 6 in normal condition needs more reduction, but I didn't because I have the space for it. So there is no need to reduce more from the length of this tooth. Okay, so and this is the final result. We see every tip, every cusp, everything is in contact. We look here, this is the heat map. Every teeth is in contact. This was his previous heat map. We saw how the force is highly concentrated on some points and the teeth are grinding each other. If we go back, we will see what happened. No, the force is normally distributed on all of the teeth without these problems. Okay, so what we did here, what is this? This is some temporary teeth. I prefabricated it with the new vertical dimension so they can hold this vertical dimension during scanning. So I made a virtual preparation and I opened his bite by like 2.5 to 3 millimeter. I can't recall, I think it was 2.5 millimeters. And then I printed this temporary bridges with shining D1 printer. After I finished my preparation, I used them as like to see how my vertical dimension will be on this patient before continuing my preparations, like testing the new vertical dimension. And I found it fine. Okay. So what we did with Blender, the protocol is done by Blender for Dental, which is a programming software program. Import the files, open the bite, virtual preparation, wax up, print or mill the temporary bridges, try in and scan. This is the video of the Blender file. This is how we open the bite, and this is making the movements on the bridges, so they are fully articulated. This is 3D printed model from Shining, D1. This is the insertion. So all of the teeth like inserted in less than a minute and all in occlusion without any interference. Okay. So now here, the follow-up after 1 week, I told the patient to come and we altered his vertical dimension. We want to make assessment for his voice and function, and hear the patient talk. Okay, let's listen. Hello again. This is our patient. We made the rehab for him, and we raised his bite by like 2.5 mm because he had like severe attrition of his teeth. Now is the test time. So we'll ask the question, a few questions for the patient. Can you say 66, please?
66.
Flavor.
Muhammad.
Do you have any problem in the pronunciations of these letters?
No, nothing to this problem.
So if it's in Kurdish, shesh to shesh.
Shesh to shesh.
I see.
Okay, so the most important.
All right, thank you. I wish those teeth serves you well, and you're a great patient. And thank you. Have a nice day. Pronounce efficiently, which means we are in the right track. Because when altering the vertical dimension, you have like some rules for the S sound, etc. Okay, so this is, he came up like before a couple of days, he had an endodontist, he had some pain in this tooth. So this is a 15 months follow-up. And we see all our preparation is subgingival shoulder finish line and how the teeth look perfectly fine. Like that. دون أسرك إجا 6 و6
6 6
66
66
66
66.
We don't have any problem
No, I
pronunciation.
do not have that.
So this like I think a year and a couple of months we have done it, except for this root canal. You don't have anything else in your teeth. Okay. No open margin. Even after 1 year, all the margins are closed. Subgingival. Okay. So now we'll take another cases, different cases on the same protocol. As one of my patients came, we have crossbite and old bridge, etc. We see here, and we see here what happened. We changed it. Take another case. This patient has reduced vertical dimension. Look what happened here and here. Look at the finish line. Everything is perfect. Another case. This patient has some crossbite here, here, here. We rectified everything. This patient has a shifted midline and his teeth was shifting downward. I don't know why. We increased his vertical dimension, I think by like 1.5 millimeters, and we restored everything back to order. Okay. Okay, so this patient, he was treated somewhere else. This case was on the opposite of our work. The other previous dentists have elevated his vertical dimension on a wrongful way. So the patient didn't have any freeway space. He was like on the high vertical dimension. So what we did here, we reduced his vertical dimension by like 2 millimeters. That was the after. So we changed the color from bleach 1 to B1, and we reduced his vertical dimension by like 2 millimeters. We'll take another case. This is guided gingivectomy. If you look here, this photos was directly after insertion. We didn't give her time to gingiva to heal. So we see the zenith line here, where was it, and here where it is now. Like we make a gingivectomy, guided gingivectomy, soft tissue, and we elevated the zenith line. Another gingivectomy. If you look here, and look here. That's another case, another guided gingivectomy and elevating vertical dimension. If you look at the zenith line of the lateral here, and you look where it goes here, with increasing vertical dimension, of course. Another case, we increased her vertical dimension by like 2 mm and made a massive gingivectomy on 4 of the teeth, guided gingivectomy. So here, this is the temporary and the old vertical dimension. This is the bridges of the new vertical dimension, and we see how it's like the old versus new vertical dimension. This is the increasing in vertical dimension we see. So you have to make the teeth in contact according to the new vertical dimension. Okay. Another case, restoring vertical dimension on upper teeth only. So like we here increase vertical dimension, but we increase it not half by half. Like we increase it 2 mm only on upper teeth, because we have some teeth on the lower side we didn't prepare, so we couldn't increase vertical dimension on both sides, because this teeth will be out of occlusion. Another case, restoring vertical dimension on lower teeth. This is on the contrary. We have some teeth here they didn't need preparation, so we increased vertical dimension on the lower teeth. We didn't increase vertical dimension on the upper teeth. All of the other cases we distribute the vertical dimension on upper and lower teeth. Here, no, on the lower teeth only. The previous case on the upper teeth only. So this like are different scenarios. This case was a massive case with a severe crossbite here. This is impossible to do with classical dentistry, dear colleagues. So we did what we do to the other cases, which is increasing vertical dimension, opening the bite, and we could like prepare this to the inside a little more. I didn't prepare from here to restore it to normal occlusion. Of course, we have some minor issue with the midline, but the case isn't a cosmetic case, it's a pathological case. Okay. Going to the next case. Oh, this is a massive case. This patient was 30 years of age, a young patient, has severe bruxism, not attrition. Look at his bite, how is it? It's becoming a reverse bite. So what we did here is treatment plan. I made full mouth rehab from the upper and the lower. But the patient was demanding cosmetic result. He wanted veneers on the interior. So what we did here, we made him veneers. And of course, he's a bruxism patient, and we made veneers, which is contraindicated, bruxism and veneers. You know, this is a glass ceramic. It's just like zirconia. Zirconia is metal, a white metal. But veneers, no, veneers are glass ceramics. So what we did here, take another photo. This is the 3D printed model, and we take a look at the case. Okay, so we see here this anteriors are veneers, those are bridges. But what we did, we distributed occlusion on the posterior teeth more and make a slight occlusion on the anterior teeth. So like we released the pressure on the anterior teeth and distributed it normally to the posterior teeth. And you can do it. You can put glass ceramic on a bruxism patient in case you have to know how to distribute your force on the posterior teeth. Okay, let's take another slide. Okay, that's his veneers. Okay, this is the insertion. This is his bridges, 4 bridges. Okay, voila. So what we used here is Orloscan 2 and AccuFab D1 with a lot of ceramics and zirconia from different, but the things we use from Shining is those two. I hope you enjoyed this lecture that was as short as possible. And we are ready for any question. Thank you. Have a nice day.